So this is a topic that comes up a lot. So, transplant is what many of us call the great equalizer of myeloma therapies, because transplant is the one tool that not every country, but probably the majority of countries with physicians here at IMS do have. Most do not have CAR T, most do not have teclistamab or elranatamab. Everybody has transplant. And the question that comes up a lot is for the patient who's in remission. So the one question comes up, if someone's completely MRD negative before transplant, do they need transplant? That's one extreme. The other question is someone, has a good response to induction therapy, but they still possibly could have a deeper response. They've achieved a partial response, but not a VGPR, not a CR. Do we take them to transplant, or do we try to deepen their response artificially with a second line of therapy beforehand before moving to transplant? The pros of doing that, theoretically, for some patients, for example, with AL amyloid in addition to myeloma, definitely deepening the responses makes a difference, because you'll find that patients will feel better as their amyloid is more controlled. For some patients who are frail or in pain because of their myeloma, better disease response might help ahead of time to make the transplant more tolerable for them. Theoretically, there's and it came up at IMS, there's a couple of points that melphalan, the actual drug in transplant, can have some effects on myeloma cells themselves and induce mutagenesis, more mutations later. This is very theoretical, that if you debulk someone beforehand, maybe the melphalan won't cause as ugly of a relapse years later. And the final theoretical benefit is that theoretically, a better disease-controlled patient will be able to collect more stem cells more easily before transplant. On the flip side, there is an army of cons to this approach. Again, if someone who's achieved a partial response to therapy, what's the downside of trying to deepen the response for transplant? One, we're taking away the great equalizer, because now we're trying to get them to some other therapy that would not actually be the transplant. But this is, again, what patients came to us to get the transplant. Two, these second-line therapies often have their own side effects. So we might use carfilzomib second line. Some patients at heart failure or high blood pressure or even kidney damage can happen from that. Sometimes we use chemomobilization as an unplanned, or just chemotherapy as a second line of therapy. Chemo has all sorts of side effects. And so we looked at the data on this, and this review was published in Blood Cancer Journal earlier this year, and the studies are mixed. I think obviously patients with better disease biology who achieve a better response to treatment do better. Patients where the myeloma responds to therapy, the myeloma responds to therapy. That's pretty obvious. But again, if someone is achieved a suboptimal response, a partial response, and you try to push them, doesn't make a difference. CIBMTR did a very large registry-based data of this back in the era mainly of chemotherapy, before modern triplet regimens with a PI and an IMiD, and found no difference, no benefit to salvage therapy. The UK group did a study of salvage CyBorD. So this sounds crazy, because CyBorD is barely even our first-line therapy anymore, but in 2011, it was a good second-line regimen, and they did find that for patients after an IMiD-based regimen that had an insufficient response, adding CyBorD as salvage therapy did potentially improve PFS. So in our review, we try to go through this. Obviously, there's no right answer. For every patient, the scenario is a little bit different, as we alluded to, in terms of, for example, AL amyloidosis or functional frailty or so forth. But for the vast majority of patients, I would argue that trying to artificially deepen their response before transplant, we're not actually benefiting them, especially because we have so many better therapies that are available after transplant. We can do consolidation, we can do doublet maintenance with the PI and an IMiD. By this time next year or 2 years from now, we'll have CAR T available in second-line therapy. And I would argue that if you have all these excellent options available down the line, why subject patients to all these additional toxicities in the beginning? And so we ended up quoting an 80s song by the Clash, should I stay or should I go? So should I stay with induction or should I go on to transplant? Our answer is go. Go to transplant. We'll figure everything else out afterwards, but don't deprive a patient of the opportunity for transplant in the frontline setting when it's been studied and that's when we know it works, just because a response is only a partial response.